katoa, ko Takitimi tōku waka, ko Rumahanga tōku awa, ko Tararua ngā paemonga, ko ngā Tikahanuru ki Wairarapa tōku iwi, ko Papaima tōku marae, ko Matthew Latta tōku ingoa. So my name's Matt. I'm one of the fifth year medical students here at the University of Otago in Wellington, so not a climate expert, but anyway, over my summer, I studied the carbon footprint of cataract surgery. So just a few preliminary kind of basic things. We know already that healthcare in New Zealand and Australia accounts for about 5% of greenhouse gas emissions, which is currently more than the aviation sector. New Zealand has announced that they'll be carbon neutral, or the public sector will be carbon neutral by 2025. When I read into that, I couldn't really tell the DHBs were going to be fully carbon neutral or what capacity it would be in, but we'll see. And we also know that we need to do specific carbon footprinting to build a picture of the carbon emissions that we are producing, because we just don't have that at the moment. And then from there, we need to work to, it's not on the slides, but we need to work to reduce the demand for healthcare, match the supply of healthcare to the demand for healthcare, and reduce emissions from supply of healthcare services, which is where the study comes into play. In terms of cataract surgery, specifically in the healthcare and the greenhouse emissions kind of sector, we know that cataract surgery is a high volume surgery. We do about 30,000 a year in New Zealand. They can take as little as 6 minutes each. It's the most done surgery in the world. And we know that the overseas estimates vary a lot, between 6 kgs of CO2 equivalent to 182, the 6 kilos being in India and 182 being over in the UK. So what do we actually do? I visited 2 public and 2 private hospitals in the Wellington region and observed 142 cataract surgeries over summer, accounting for all the ophthalmologists in the Wellington region. We then measured the emission sources for procurement, which was dollars, waste disposal, which was kilograms of waste, travel, kilometres travelled, and electricity consumption, which was kilowatt hours. From there, we applied a relevant emissions factor to determine the kgs of CO2 to get a very simple equation, which is emission source times emissions factor, gives you kgs of CO2. Of course, there's a bit more to it than that. We had to decide on inclusion and exclusion criteria, but that was very specific to cataract surgery and was based on prior studies that have been done. And these are the results we got. So as we can see, following closely with what Rick was saying yesterday, procurement is by far the most carbon dense, essentially, part of the cataract surgery. That 84% due to procurement can be further broken down into 77% from the procurement of surgical supplies and 7% from the procurement of pharmaceuticals, and that just kind of reflects the surgical nature of cataract surgery. The 15% from travel is about in line with other places. That can be altered further. Essentially, the more patients you do per surgical list, the less carbon you make because the staff have to travel less. And as we can see, electricity accounts for 1% and waste accounts for, says 0%, but it's really 0.4%. That's just due to the the electricity is due to the fact that we have a really low emissions coefficient in New Zealand. We've got a lot of sustainable energy production, and that will hopefully go up further to 100% at some point, can't remember when. And the waste disposable reflects that in the Wellington region, we use energy recovery for our waste, and a lot of the places were recycling, which definitely helped. And that made up 152 kilograms of CO2. I think I might have actually said most of this, so we'll skip through that. We also, because we studied public and private, we could make a public-private breakdown. And as we can see, there's a few variances here. So the private sector's got a much larger procurement aspect, and that is likely due to the smaller scale of economy compared to the public system. Essentially, for the same goods, it costs more because they're buying less of it. Although, as you can see, it's still quite significantly different. But they also have less travel. The travel sector is a lot smaller than the public travel sector. And that's just due to the fact that in private, they're not teaching registrars how to do surgery. They can just go in there and do the surgery quickly. So, I mean, in private, they're seeing about between, I'd say, 12 and 18 patients per list, whereas in the public sector, they were seeing maybe 3. So yeah, that just kind of reflects the different environments. I don't like kgs of CO2 equivalent. They're an annoying number. I like to see things in pictures. So what does 152 kilograms of CO2 actually look like? Well, it would take 45 square meters of forest about a year to absorb that much CO2. So that's about the size of a 1-bedroom apartment. It's also the same as an economy flight from Wellington to Auckland, and there's 62 litres of petrol. So yeah, per cataract surgery, per 6-minute surgery, it's quite a lot of carbon that we're burning through. On a larger scale, it's even bigger again. So if we multiply that 152 by 30,000 surgeries, you get 4,500 tonnes of CO2 per year, just from one surgery of many surgeries that the specialty does, of a specialty that studies that and nothing more. So yeah, it would require about an area of forest twice as large as the Wellington CBD to be absorbing CO2 for a year in order to neutralise that carbon. How does this compare to international studies? The UK study was slightly different to ours. They included perioperative visits, and they were found to have 182 kgs of CO2, about 20% more. And it's likely that the pre and post-operative appointments and the travel related to that and the electricity use kind of accounts that 20%. They also have very different emissions coefficient. They use a lot more coal than we do, so their electricity costs a lot more. The other really interesting study was the Aravind Eye Centre eye care system in India, and they produce about 6 kgs of CO2, which, as we can see, is significantly less. There's a lot of reasons for this. Their procurement was next to nothing. They make a lot of things locally, like surgical gowns, blankets, and instruments. But at the same time, while they're reusing a lot of instruments and sterilising a lot of instruments, they have comparable surgical outcomes to the UK. The metric that they base their post-operative infection and other complications off is on developed countries' complications sense, and they're well within them. They have a much higher caseload. Each surgeon works 2 tables at a time, so they can do between 750 and 1,500 surgeries a day. Yeah, they're pretty good. And the other thing is they separate their contaminated and non-contaminated rubbish with the kind of idea that just because it's been used doesn't mean that it poses a health risk to patients. They can really get through, yeah. As long as it doesn't have blood or other infectious content on it, it gets sterilised and reused. So what can we do about it? So as I said before, there's the reduce demand, match supply and demand, and reduce emissions from health supply services. This study focused mainly on the last section, but there is still actions that can be taken in the first 2. Reduce demand, increase the role of public health and upstream changes. So working on things like diabetes, smoking, UV exposure will all reduce the incidence of cataracts and therefore require less cataract surgery. Matching supply and demand, just setting some guidelines to increase efficiency and decrease treatment delay. Yeah, pretty straightforward stuff. And then reducing the emissions from the supply of the health service. So in New Zealand, Pharmac's upcoming role in the bulk purchasing of surgical supplies represents a major opportunity to improve both the measurement of emissions related to procurement and leverage reductions in emissions during cataract negotiations. And it would also be benefited if private and public could find some way to be friends with each other and buy from the same source. The power of economy would be much larger, and therefore they'd have more leverage, and the carbon cost of procurement would be a lot less. A recent survey showed that many of the reuse and recycling practices in India would be acceptable to American surgeons if cost and safety were maintained, which, as I previously said, they are. That kind of comes back to the concept once again, is that just because it appears cleaner, just because it appears more sterile, doesn't necessarily mean that it is. That some of the older techniques like sterilising are still very valid and do have a much less environmental cost while maintaining the health standards. And one last thing kind of on transport, large hospital systems are in a position to influence transport systems. They are major employers and they're a destination for thousands of people each day. Innovative approaches include partnerships with local governments to further subsidise public transport for patients and employees. And that's just another little thing that's just for hospitals in general, not for cataract surgery specifically. But yeah, thank you very much.